friends, good evening. Today I will be explaining you about the HIllsach lesion arthroscopic repair. Myself Dr. G. Krishna Naresh Goud, arthroscopy and sports medicine specialist. Here we can see the posterior portal. The camera is going through the posterior portal and I can see up to the inferior margin of the glenoid. My anterior portal needle is coming in the rotator interval. You can see the needle is coming from high and it is pointing towards the inferior part of the glenoid bone. If you see, the rotator interval is like a triangle made up of three muscles. The top one is a biceps, the subscap on the right side, and base is formed by the glenoid. So now the needle should come from the top of the triangle so that it will be easy for us, for our instruments to use as a periosteal elevator or some other instruments like that. Once I made sure that the needle is passing through, I have dilated it with the use of a dilator and passing and dilating it with using a 8 mm cannula there. You can see the cannula coming inside over the dilator. That is my anterior portal. I have fixed my anterior portal. You can see it. The anterior portal is directing towards facing the glenoid inferior part and it is coming from above. Now if you can see, this is the biceps. The second portal should be either posterior to the biceps or anterior to the biceps, but in this place, in this scenario, the place or the gap is less. So I am trying to come posterior to the biceps. You can see this needle coming posterior to the biceps. It is very far, so I am readjusting it to take it just beside the biceps. That is my anterior superior portal coming in. The difference between the two portals should be 30 degrees. That is a specific angle called azimuth angle. You have to maintain 30 degrees of space, 30 degrees of angle between the two portals for your scope to see properly. And with this anterior portal or anterior superior portal, my over the needle I will dilate with a dilator. I will dilate with a dilator and a Wissinger rod, and I will change my viewing portal from posterior to the anterior superior. With this, there are two advantages. One, I can see the glenoid end-on view, and elevation of the periosteum and the labrum will be easy from the anterior superior portal by seeing or visualizing. And I can see the posterior part of the humeral head as well, like HIllsach. You can see the HIllsach there, and the HIllsach also can be treated with the same portal. If I have to use or if you have to treat the posterior labrum also, I can use the same portal for as a viewing portal, and the working portal will be different. So now I am seeing through the anterior superior portal and I am seeing the HIllsach. I can see this HIllsach here, a huge HIllsach lesion. The bare area is behind. You can see small bumpy like thing in the anterior part. That is a HIllsach lesion. One should know the difference between a bare area and a HIllsach. Bare area is a very smooth area, but HIllsach, if you see, it will be a concave or a convex, or sometimes osteophytes will be seen like this, as you are seeing in this picture. I am trying to remove the osteophyte with the help of a curette and make it smooth. Once I make it smooth, I will try to remove the surface with the help of a shaver to make it bleeding ends to come out. That will be easy for us to heal, because whatever the surgery we are going to do is called a remplissage. The remplissage is a derivative of a French word, namely as remplissage means to fill up the defect or to fill up. So with the help of a remplissage, what we are trying to do is attaching the infraspinatus tendinous part onto the filling the defect, so that it will be acting as a hindrance, or it will stop it from going and dislocating as an additional factor apart from the bankart lesion. So now you can see, as I was explaining earlier, I am trying to scrape off the superior surface or the outer surface of the HIllsach lesion and make it even. Once I am satisfied, then I will start shaving it. There are some striations of the labrum also can be seen, so which are coming into my picture with a which are coming into my picture and disturbing my view. So this I will shave off with the help of a shaver. So this is how you should see the HIllsach. So basing on the HIllsach, MRI is a very good investigation to find out the HIllsach. If you want to see how a HIllsach and a bare area has to differentiate on an MRI, the underlying hyperintensity on the humeral head will be there in a HIllsach, but you will not see anything there as a bare area. So that is a key takeaway for a surgeon who is in the early stages of their career to find out a HIllsach or a bare area. And CT scan will be better to measure the depth and the area of the HIllsach. Basing on the HIllsach, you can say differentiate into different kinds like engaging, non-engaging lesions, glenoid on track or off track. That I will explain in the further videos. So now you can see the bleeding bone we are able to see. Now with the help of awl, I am trying to see the actual length of the HIllsach. So I am trying to see the anterior margin. I am trying to see the posterior margin. Once I am satisfied with the amount of the depth of the HIllsach, I will try to put my anchor as low as possible, just above the cartilage level, so that when I use this anchor to pull or to fill the defect, my anchor or my thread will pull the shoulder humeral head back and above. That will be easy, or that will help us in fixing the shoulder. So this is what I am trying to find out. This is the low area. I am satisfied with this, and now I am going in with the awl. You can see the awl is just above the HIllsach region and just above the cartilage of around maybe like a 2 to 3 mm above the cartilage level. Once I dilate with the awl, I will use a metal anchor to go inside. I always use a metal anchor in the HIllsach area because HIllsach is mostly a cancellous bone. The amount of cortical bone in here is very less. So that is the one more reason why we are using just below the cartilage or just above the cartilage level, and metal anchors what we are using. So this is a metal anchor going in. Once the metal anchor goes in, I will disengage the threads and try to see whether it is working or not. Whenever mostly I will use a single anchor, which is a double loaded anchor. I will try to take 4 bites in 4 different corners and try to fix it over the capsule. So the same thing we have done here. This is a double loaded anchor. You can see 2 tiger threads and 2 blue threads. My cannula, you can see I am the cannula I will pull out just outside the capsule, and through the same cannula I am changing the direction, and using a bird beak I am coming through a different hole, and I am taking a tiger thread here and a different area. Again, once it is done, then I will go inside, go out, and again come back through a different hole to take the another tiger. The same like I will take the another blue thread also. Once I take all these threads in a diamond shape or a plus shape, I will tie the horizontal first, then followed by vertical, or whichever you are comfortable. I will try to fill the defect.